Welcome, everyone. Thank you for joining our presentation today, Billing for Article 29I Facilities for Opt-in Providers. My name is Yvette Kelly, and I'm with the Managed Care Technical Assistance Center, and I am joined by my colleague, Boris Vilgorn. Also joining us today is Tanya Rolson from the State Department of Health and Mimi Weber from the New York State Office of Children and Family Services. Just some housekeeping before we get started. Please note that this presentation is not the official document, and for full details, we're going to ask that you please refer to the provider and billing manuals. Also, we've made every effort to ensure information and timelines are current as of the date of this presentation. So here's our agenda for today. We will begin the presentation with a brief overview, which will be provided by our state partners. We will then discuss service and rates, claim requirements, coding, additional billing rules, and covered populations before leaving you with some resources. And with that, I'm going to pass it over to Mimi Weber.
Thank you, Yvette. Hi, everyone, and thanks for joining the webinar. We just want to take a moment to review why Article 29I is important. And it's important because it was created to allow our voluntary foster care agencies to provide and bill managed care plans for healthcare services to our most vulnerable kids. 29I also represented an opportunity for us to do meet a couple of policy goals that we've been working towards over the last several years. The first and foremost, it is our full hope that through 29I we'll be able to raise the level of healthcare services that are provided to kids that are in your care. We're also hoping to achieve some level of standardization. And with all this comes, of course, some administrative work. We recognize that this represents a new way of doing business. It'll mean a new way of your healthcare providers that are employed at the foster care agencies, a new way of them documenting their services. It'll certainly mean a new way of your back office operations doing business differently. So we recognize that this magnitude of a change can be a little overwhelming and intimidating, and we want to make sure that we're providing all of you with the level of support that you need in order to successfully make it through this transition. So our message to you today and going forward is that you have partners at the State Department of Health, at the Office of Children and Family Services, and partners at MCTAC. We are here to help guide you through this process. With that, I would like to thank Boris and Yvette for all of their efforts in making today's presentation happen, and I certainly want to extend a huge thanks to our partners at the Health Department for pulling this together, and especially to Tanya for her presentation today.
Thank you, Mimi, for that overview. And that brings us to the purpose of today's presentation, which is to review the billing requirements for services provided by 29I licensed health facilities, which are administered by the New York State Department of Health and Office of Children and Family Services. Again, I encourage you to review the billing guidance that is available. When doing so, please note that this manual provides billing guidance only and does not supersede regulatory requirements or procedures. So Article 29I health facilities have the ability to provide two categories of services. These include core limited health-related services, which are mandatory, and other limited health-related services, which are optional. Today's presentation will focus on billing Medicaid fee-for-service for both these mandatory and optional services. In order for voluntary foster care agencies to be prepared to deliver for these services, there are several fundamental requirements that need to be met. This includes being licensed. In order to provide core limited health-related services and/or other limited health-related services, voluntary foster care agencies must be licensed. Agencies who are not licensed are not authorized to provide these services. To become licensed as a 29I health facility, providers must submit the appropriate application. All VFCAs that are licensed as 29I health facilities will receive a New York State DOH-issued license indicating authorization to bill for these services. Additionally, for services to qualify for Medicaid reimbursement, the youth health or behavioral health record, treatment plan, service plan, and/or plan of care must reflect that the services provided meet the following criteria. That the services were medically necessary and appropriate, and the services were rendered by qualified practitioners within their scope of practice as defined in relevant state law. For all eligible providers who plan to bill Medicaid, they are required to be enrolled as a Medicaid provider in order to receive reimbursement for delivering a Medicaid service. 29I health facilities must be enrolled with a category of service code 0121 to bill for core limited health-related services, and a category of service code 0268 to bill for other limited health-related services. For more information on how to become a Medicaid provider, please visit the eMedNey New York website, and we've provided the link here. In terms of designation, 29I health facilities may provide children and family treatment and support services and children's home and community-based services as part of their other limited health-related services. Those facilities who wish to provide CFTSS and HCBS are required to receive the appropriate designation or designations from the state. 29I health facilities providing laboratory services must have a valid clinical laboratory improvement amendment certification and only provide laboratory services outlined as such. Core and other limited health-related services must be provided and billed for separately. 29I health facilities may not separately bill for activities performed by a professional when the full-time equivalent for that position is funded within the Medicaid per diem rate for the provision of core limited health-related services. Facilities may allocate percentages of individual practitioners' FTEs to core and other limited health-related services based on actual time spent providing those services. And when doing so, facilities must appropriately allocate the costs associated with each type of service and the annual cost report that gets submitted to the state. In circumstances where a child is receiving services from an Article 29I health facility and a community provider, such as an outpatient mental health clinic, concurrent billing may be acceptable. It is only acceptable when a clinical need is identified that is distinctly different and non-duplicative to those needs being addressed by the Article 29I health facility, and it is determined that it is medically necessary to provide those services concurrently. And so just to give you an example of what that might look like, consider a case in which the Article 29I therapist is providing individual therapy to the child and identifies the need for family therapy. The therapist determines that it is necessary and beneficial for the family therapy to be provided in the outpatient mental health setting. In this example, billing for both the individual and family therapy would be appropriate and allowable. In this case, both the Article 29I therapist and outpatient mental health therapist would have separate treatment plans addressing different goals and objectives in therapy, thus substantiating distinct clinical needs and interventions for each service. In accordance with best practice, the Article 29I therapist and outpatient mental health therapist would be expected to collaborate with consent from the child and family to ensure alignment in their treatment interventions. Next, we'll touch upon some billing basics associated with the delivery of these services. Core limited health-related services are reimbursed on a per-child, per-day basis. Other limited health-related services are reimbursed daily and should be submitted on separate claim forms, separate from not only core limited health-related services, but from separate other limited health-related services as well. Claim submissions must adhere to the 90-day timely filing rules for Medicaid fee-for-service, and a reminder that these services will be billed Medicaid fee-for-service from February until July 2021. Next, we will detail the services and rates associated with the core limited health-related services. So all licensed Article 29I health facilities are required to provide or make available through a contract arrangement all core limited health-related services. And as I've mentioned a few times before, medical necessity must be documented in accordance with the 29I health facilities licensing guidelines, which is available at the link provided here. So what are core limited health-related services? So there are a total of 5 core limited health-related services, and they include the following. Skill building, which is inclusive of counseling and interventions, such as individual and family counseling. Nursing services, which may include routine screening for a number of health and behavioral health disorders. Medicaid treatment planning and discharge planning, which supports the coordination of services. Clinical consultation and supervision, which may include working directly with treatment team providers, and the Medicaid Managed Care Liaison Administrator role, who will be expected to coordinate with the plan's foster care liaison. And so as I've only provided examples of what is included in each of these categories, I'm going to remind you to please refer to the 29I Health Facilities License Guidelines for more information regarding the description and allowable services under each category. So these services will be reimbursed by a Medicaid per diem rate. The rates for these services are associated with the 29I facility type, which is indicated on the agency's license, and the rate for these services includes routine transportation. Rates for core limited health-related services will differ based on both the level of care and the facility type the 29I health facility is operating, with one rate assigned to each of the 13 facility types. Since a 29I health facility may operate more than one facility type and one or more levels of care, it may be necessary for a facility to bill several different core limited health-related service rates. And again, rates billed must correspond to the rate for the facility type in which the child or youth is residing. So there are some billing limits that providers must be aware of when billing for these services. Some of these limits include that only one core limited health-related service rate per day for each individual child or youth can be billed, that these services are billed daily and can be submitted with a range of multiple dates of service on one claim, that the Medicaid per diem rate is paid for the duration of the child's stay in the 29I health facility, and the Medicaid per diem is not reimbursable after the youth's 21st birthday. So again, those are just some limits to be mindful of. So this slide details the different levels of care and facility types. As a reminder, core limited health-related services rates differ based on, again, both the level of care and facility type. So let's find that here. Next are the rate and procedure codes associated with each level of care and facility type. And while I won't go through all of them in detail, I will say that you can refer to Appendix B of the billing guidance to find out more about the rate codes and procedure codes associated with these services. It's also important to note that core limited health-related services are not subject to regional reimbursement differences, as the Medicaid per diem rate was calculated as a statewide Medicaid rate. So now that we've looked at the services and rates for core limited health-related services, we'll now focus on services and rates for other limited health-related services. We'll walk you through that. And as a reminder, in order to provide other limited health-related services, These services must be included in the agency's 29I license and may require separate state designation prior to the delivery of services. So these services may be provided to youth who are in the care of any 29I health facility, including children and youth in foster care, youth placed by the Committee on Special Education, babies residing with their parent who are placed in a 29I health facility and in foster care, and youth placed in a foster care setting certified by the local Department of Social Services. There's also an opportunity for youth to be eligible to receive other limited health-related services up to 1 year post-discharge. In order to be eligible, the following must apply. The youth is under 21 years of age and in receipt of services through the 29I health facility for an episode of care and has not yet safely transitioned to an appropriate provider for continued necessary services, or the youth is under 21 years of age and has been in receipt of CFTSS or Children's HCBS through the 29I health facility and has not yet safely transitioned to another designated provider for continued services in accordance with their plan of care. Agencies may also bill for other limited health-related services for individuals who are 21 years of age or older when the following applies. The youth has been placed in the care of the 29I health facility and has been in receipt of other limited health-related services prior to their 21st birthday, and the youth has not yet safely transferred to another placement or living arrangement, and the youth and or their authorized representative is compliant with a safe discharge plan, and the 29I health facility continues to work collaboratively with Medicaid to explore options for the youth safe discharge, including compliance with court-ordered services if applicable. For other limited health-related services, the Medicaid residual per diem is not reimbursable after the individual's 21st birthday. Additionally, adults over the age of 21 are not eligible for CFTSS or Children's HCBS. So other limited health-related services include children and family treatment supports and services, children's home and community-based services, and Medicaid state plan services. And again, I'm just going to refer you to the Article 29I licensure guidelines for additional details regarding requirements for the delivery of these services. So we'll talk a little bit about what other limited health-related services do not include. And you can see that here, that it does not include surgical services, dental services, orthodontic care, general hospital services, including emergency care, birth center services, emergency intervention for major trauma, or treatment of life-threatening or potentially disabling conditions. These services, along with pharmacy services, should be billed directly by these providers to Medicaid fee-for-service. Other limited health-related services are reimbursed on a standardized fee schedule, and here is a link that can be found here where you can locate that fee schedule. Facilities may bill for encounter-based other limited health-related services that are provided to meet a child's individualized needs and are included in the agency's 29I license. All unit limits are soft limits and can be exceeded in accordance with documented medical necessity. And if a service or procedure code requires time beyond the 15-minute unit in the fee schedule, the agency may add additional 15-minute units to the claim in accordance with medical necessity. And so here's a grid outlining timed units of service per encounter of service. Please note that these timed units do not apply to children and family and treatment support services or children's home and community-based services. Providers can find relevant rate codes and other billing information presented in today's webinar and the resources provided here. We've also provided a link to the CFTSS and HCBS billing information as well. And while core limited health-related services are not subject to regional reimbursement differences, this is not the case for other limited health-related services. These services are subject to the regions as defined by the Department of Health and assigned to providers based upon the geographic location of the provider's headquarters. And so you can see the breakdown here and refer to it as needed. And with that, I'm going to pass it over to Boris to take us through the remainder of the presentation.
Excellent. Thank you, Yvette, for the presentation. And I'll continue with the next set of areas to cover, the first one being the claim requirements. So through the claims requirements or billing requirements, again, we want to make sure folks refer to the billing and coding manual that will lay out the requirements as well as the clean claim rules that are specified both in those manuals and the billing tool, and we provided the link below. It's also important to note that both paper and electronic submission of claims will be supported for all claim types, and all required codes and modifiers must be used when submitting claim for these services. And again, please refer to the manual appendix for the complete listing of CPT codes and associated modifiers. I will be going through some of the codes and providing some examples through it, but again, as always, and as was mentioned before, please make sure to refer to the all appropriate manuals. So as we continue with the billing requirements, it's important to note that all claims must include the national provider number, which is referred to as NPI, and of course the ones that are associated with 29I health facility. For 837I and UB04 claims, the 29I health facility will enter the rate code in the header of the claim as a value code. And you do this in a value code by first typing in 24, followed immediately with appropriate 4-digit rate code. Other billing requirements that's important to note, again, for the use specifically for 837I, which is the electronic format, or UB04, which is the paper format for core and other limited health-related services. Again, important to note that all claims will require at least the following, and there might be more requirements as when you refer to the manual that you can find. But at a minimum, you will need to provide a primary diagnosis code using the diagnosis code, the International Classification of Disease, 10th revision, clinical modification, or as most of us probably know it as ICD-10. You would, of course, need to enter the rate code, procedure codes and modifiers, unit of service, patient reason for visit code, and revenue codes. And again, there might be other requirements, so please refer to the manual. As I mentioned earlier, these are some of the coding that we want to review with you as well, and point to some of the examples and some of the areas that we wanted to highlight. So the procedures and modifier code combinations must be adhered to in order to ensure appropriate rate payment. And again, it's important to make sure that the procedures and modifiers and those combinations match, and as they are laid out in the manuals and the documents provided by the state. These combinations do indicate that the claim is for services provided to children and youth in the care of the 29I health facility. In instances where there are a requirement of 2 modifiers, please make sure that you enter both modifiers. Must be present, of course, and it does not require that are provided to indicate them in an exact same order for every claim for payment to be made. But again, it's important to make sure you are including both modifiers. And for other limited health-related services, if the individual encounter has multiple procedure codes, the principal procedure code will be a billable code that you should be including, and other procedure codes will be included as non-billable for the encounter. And again, there's more in the manual, specifically in Appendix C for billable and non-billable codes. And we will, in the next few slides, review some of that as well. So an example just to provide in regards to when we talk about billable and non-billable procedure codes. So one example scenario is you have a child who comes in for an office visit on a Sunday, and while there, a review of their medication regimen was completed. So the way you would approach billing is you would be billing as an office visit, rate code of $45.94 in this particular instance. You'll be using that billable procedure code 99204, and of course, with that rate code of 4594. You will also be including non-billable procedure codes associated with that Sunday office visit. And you will be indicating the pharmacological management procedure code of 90863, and also indicated that this visit has occurred at times that were other than regular scheduled hours, because you were seeing the child on a Sunday, and you would indicate a procedure code of 99051. So non-billable codes are not reimbursed separately, as they are part of the same encounter as the billable code. So why should a provider include non-billable codes? Well, it's really important for a reporting accuracy to include every service that was providing during that visit. It provides details on how complex the visit was, and it all captures all the services you're providing over a period of time. So again, important to make sure you include both billable, of course, but also the non-billable codes when submitting claims. For core limited services, providers can use the revenue codes 0529 and 0519. For other limited health-related services, we have the following number of slides that will give you a breakdown of potential revenue codes by each specific service. So I'll just go through some of them just to, again, highlight some of the revenue codes. So on this particular slide, we're talking about alcohol and drug testing, developmental testing, psychotherapy, both individual and family, psychotherapy group, neuropsychological testing, evaluation services. So for all of these services, you can use revenue codes 0513, 0520, 0900, and 0914. For developmental testing and neuropsychological testing, you can also use, in addition to those four codes, 0918. And when it comes to psychotherapy, either individual, family, or group, you're also allowed to use a revenue code of 0916. For this next set of codes that we have, you have psychiatric diagnostic examination and smoking cessation treatment. Can use similar codes as with previous ones of 0513, 0520, 0900, and 0914. For office visit, you have one revenue code, which is 0529. Office visit preventive medicine is 0770. And for ECG, the revenue code is 0730. And for the continued discussion on services and other services and revenue codes, we have the screening, developmental, and emotional, which again follows similar code structure as some of the other codes I already talked about with 0513, 0520, and so forth. We have hearing that you can use code of 0529, evaluation of speech of 0449, and immunization administration of 0771. When it comes to laboratory services, you have a number of different codes that start really with 0300 and go through 0312 and also 0319. But again, please make sure that you refer to the behavioral health outpatient revenue codes that we have in our MCTAC listing as well, and the tools that will be available for you to use. Some additional billing rules that we wanted to cover as well today. So what happens on day one with Go Live, please make sure that Medicaid billing rates will be loaded into the provider file. But also, it's important to note that the billing is determined by dates of service. So just to give you one example, so even if you provided services on January 31st, but submitting the bill in February, you should still use the old methodology of billing. So again, the date of service is an important determinant of if you're still using the old methodology or the new methodology of billing. So just wanted to make sure providers pay attention to that and highlight for billing purposes, especially during the transition time. For documentation and authorization, wanted to highlight that there are no changes to documentation requirements or authorization requirements. Providers can continue using the same timeframes and documentation for continuity of care. And a couple of other areas to touch base, especially around the absence categories. And in particular, when it is permissible to claim the Medicaid per diem during the absence category. So for the rate, for the consecutive days 1 through 7 per episode of absence of the following: trial discharge, non-secure legal detention, or absent without consent is allowable. And for the rate for consecutive days 1 through 7. Continuing with the allowable absence categories or permissible ones, you can use the rate for all days of episodes of absence of the following: the weekend visit, school and religious holidays, vacation days, which also includes stay at camp, up to 21 days per calendar year you can utilize for the vacation days, visits to potential foster or adoptive parent. There you can use up to 7 consecutive days per visit, organized school trip, a number of other activities, including like foster care youth attends and is a resident at an in-state or out-of-state college, university, and so forth. You can also use it, and it's permissible to use for respite care and services for non-institutional and institutional. There are categories where it is non-permissible to submit a claim. And again, the non-permissible categories include inpatient hospital stays, other residential facility settings, days when the entity is reimbursed via Medicaid. However, if the Article 29I health facility has advised the fiscally responsible local Department of Social Services, or LDSS, that they will not accept the return of the absent youth in foster care to their agency, you are then none of the absent days, if they would otherwise fall into permissible absence category, are reimbursable for the purpose of the core limited health-related services rate, and 29I health facility must discharge the youth. And again, just like with other information we have provided today, please refer to a full list of absence categories when it is not permissible to claim the Medicaid per diem. See the billing manual for that full list. And as always, please remember, claim test, claim test, claim test. And as much as possible, give yourself as much time to make sure you're testing your system. You're also testing the system that will be processing your claims. At the same time, you're testing your system. So it's really crucial that you do as much claim testing as possible. And so with that, I will turn this over to Tanya, who will go through some of the population served by 29I facilities.
Thank you, Boris. So we're just going to review populations served by the 29I facilities. So most of the children and youth are Medicaid eligible simply by the virtue of foster care status. So this includes children and youth who are United States citizens or have satisfactory immigration status. 29I health facilities may provide core limited health-related services and other health-related services to the following populations. And we're going to go to a chart. So to orient yourself to the chart, this is all Medicaid fee-for-service enrolled children, and on the left-hand column are those populations or placement categories that the kids are, or how they're placed in the 29I facility. So for foster care placement in the care of a 29I in New York State and kinship certified placements, Medicaid fee-for-service pays the per diem for any days enrolled in, the enrollee isn't placed in the 29I. So those two populations would receive a per diem payment for the days the kid is enrolled and placed in the 29I. The next two categories will not be are not eligible for a per diem payment. So that's the kinship placement not certified, so there will be no per diem payment. And for the CSE placed child or youth, there would be no payment. And so there's a little note there that says that, you know, it refreshes everyone on how the CSE kids payment is paid, but it will not be paid through the Medicaid per diem. So moving on to additional populations here for the core health per diem, we have 8D babies. Medicaid fee-for-service pays the per diem for the days the child is placed in the 29I health facility, and that's according to whatever facility level that child is placed in. Out-of-state placement, non-4E, Medicaid fee-for-service pays per diem for days the enrollee is placed in the 29I. Out-of-state placement 4E, to be enrolled Medicaid in the state in which the child is living. So there would be no per diem for this, for the out-of-state 4E child paid through the per diem here. So former foster care adults, same, it does not apply. They may be receiving some other services, but they will not be receiving a per diem payment for former foster care adults. And just a few more categories here on the core health. Children placed in a setting that provides comprehensive care, such as an inpatient setting, nursing facility, RTS, and so on. The per diem is not billable while the child is in one of these settings, so that would be a non-permissible category. Children under the custody of the juvenile justice system, again, there will be no per diem paid for that child. And then we have an additional category, which is fairly new, predispositional placed youth. Core health services are paid by the LDSS. So now moving outside of the per diem, we're looking at other limited health related services, and we're going through the same populations, but we're identifying other limited health related services. So if a 29I has the ability to provide these services for the first two categories, you're going to see that foster care placement in the care of a 29I in New York State, Medicaid pays for the other limited health services, as well as kinship certified placements. Kinship placement not certified, Medicaid fee-for-service will pay reimbursement based on the appropriate fee schedule. For CSE kids, the CSE LDSS pays for other limited health services documented in the IEP. Anything outside of the IEP can be billed through other limited health services. So 8D babies, out-of-state placement, and so on. You'll see here 8D babies Medicaid fee-for-service reimburses for other limited health services provided by the 29I. Same for out-of-state placement non-4E. Out-of-state placement 4E to be enrolled in Medicaid in the state in which the child is living. And then for former adults older than 21 that are still in the care of a 29I, Medicaid fee-for-service pays for the services provided by the 29I as long as there is no break in service. And the 29I has documented the efforts to safely discharge the adult. So although these instances may not be super common, there are some instances where some kids are getting services beyond their 21st birthday. Children placed in a setting that provides comprehensive care, an example again is the RTF. Other limited health services are not billable while the child is in one of these settings, so there will be no 29I other limited health services delivered or reimbursed. Children under the custody of a juvenile justice system, again, this does not apply. And then predispositional place use, fee-for-service reimburses the services provided by the 29I for other limited health-related services. So if you have any questions regarding any of the content in today's webinar, please email the bh.transition mailbox at help.newyork.gov, and we will disseminate your emails to the appropriate team members, and we will get back to you. That goes for any of the billing or any of the 29I structure or transition that we've talked about today. Then we have a few additional resource pages that you can reference after you've reviewed the webinar. And again, if you have any questions on those, just refer back to the bh.transition mailbox for questions. And thank you for joining us today, and we appreciate it.